Yeah, we're talking about bloodless surgery and Jehovah's Witnesses, and with us is Dr. Omokoye of Limad Hospital. It's a pleasure having you on SaharaTV, sir.
My pleasure too. Good afternoon.
Like I said, we're talking about patients, what to do when transfusion is not an option. Something that you have interestingly become an expert in, a kind of a go-to person with this. The first question I'd like to ask is, how did this happen? How did you become, by default, an expert, so to say, about Jehovah's Witnesses patients with regards to bloodless surgery, sir?
Well, it's been I've been dealing with Jehovah's Witness organization and members for close to 20 years now. I started with that with my former boss, Dr. Rahman of AMCAD, and under his tutelage, he kind of introduced me to the challenges involved in management of Jehovah's Witness. And over time, while I was with him, we have had a lot of people, a lot of Jehovah's Witness with challenges as regards to management of medical and surgical conditions. And the main challenge, because he tried to, before then, I was, let me just confess, say forward, I was cynical from school days. Right from my early days as a medical doctor, I was cynical about the belief, because the general knowledge was that if transfusion is going to save life, why not? Why should someone, opt for no blood transfusion when it is an option to saving life, or for quick relief, recovery from medical or surgical illness? But when I was challenged, it was a very interesting challenge, which under his tutelage and encouragement, I got used to. And it's been over 18 years now that I've been dealing with witnesses. And quite frankly, I have not regretted it. And quite frankly, against my former opinions I have with it, it's been a tremendous encouragement, to treat them even without blood, and I've had success, in that regard.
Now let's talk.
If you call me an expert, not really an expert, but I think I'm a little experienced in that.
Interesting.
Worthwhile experience.
That's quite interesting. Now let's talk a little bit about patients in general who refuse transfusion. One question that has troubled a lot of people is that, is it only Jehovah's Witnesses that actually refuse blood transfusion? And from your experience, over the years, is it just restricted only to Jehovah's Witnesses? Or are there people who also say
there are some people that will come out, will have conditions, surgical or medical, I will tell you point blank that they don't want transfusion. Some of them, not for medical reasons, some of them just purely because they don't, they are averse to taking another person's blood into their own. And some of them are informed because of maybe experience of having a relative having a transfusion and it goes down south and there was complications. And ever since then they said, no, I'm not going to take, they are not Jehovah's Witness, and I've come across a couple of them like that.
Interesting. Now, let's go back to Jehovah's Witnesses. Publications of Jehovah's Witnesses organization actually are definite about prescribing or saying, they're not allowing certain components of blood, especially whole blood cells, red blood cells, platelets and plasma, for example. I want to ask your perspective on this. Are there variables or alternatives that Jehovah's Witnesses from your medical perspective, cool?
Yeah, of course. I would like to say from onset that Jehovah's Witnesses have really impacted me. The belief about blood transfusion has impacted me a lot, and that's challenged me as a person and few of my colleagues too, to actually, seek that solution of what if there is no blood, what then can we do, And we found that, especially I gained a lot from the publications of Jehovah's Witness, coupled with some, there are medical personnel now, surgeons, medical personnel, now that are not even Jehovah's Witness, probably they get their inspiration from Jehovah's Witness and they are into non-blood transfusion management of medical and surgical cases. So from these two, I get, to answer your question partly, it's all about taking up the challenge. You know that there are some people, especially Jehovah's Witnesses, that will not take blood transfusion. You don't want them to have that kind of crisis in the first place.
Yeah.
That's the first thing. You don't want them to come down with a situation where we'll now be battling with building our blood. So preventive measures is the first thing. And that's why when I liaise with the hospital liaison committee, I tell them, please tell our sisters, tell members that if they have medical problem or even surgical problem, they should not wait until late hour before presenting to the hospital, especially if the medical or surgical problem will involve blood transfusion or will involve maybe low PCV, anemia or something. They should report early so that we will take preventive measures so that it won't go to a crisis level. You understand? So that's the first thing, the preventive measures. Then the second thing is the conservation of blood itself. You know, let me say medical purpose now. For example, they taught us, from the journals, from the publication of witnesses, there are some laboratory tests that we want to do. For a doctor who is liberal about blood transfusion, he can order for laboratory tests 10 times a day. Not minding because if it's short, it will transfuse. That's always an option to them. But for someone who is managing witness, we know how to manage, blood. You don't just, except it is absolutely necessary.
So what are the derivatives that you use in such instances, sir?
Derivative, we don't use whole blood, the plasma and the serum, like you said. I think the whole thing is the witness, based on faith anyway,
exactly.
Because there's defined injunction that you should not take blood. Of course, sometimes we work with our faith too. Okay, if my faith says this and I'm faced with this, what do we do? I think that's what inspired the body of knowledge about what do we do in this kind of situation. So, the idea is that our body, as it is made, is self-regenerative. Like we used to say, we die and live, we die and wake every day. As we have now, some cells are dying, some cells are being replaced. Exactly. So we believe in the self-regenerative process of the body. That if there is blood loss, the body will try, the homeostatic mechanism will try, come in play and replace it. So we now, okay, if that is the case, what are the processes involved in forming blood?
Okay.
And in exploring that, we found that there are some processes involved in forming blood in the body, and we'll come out with some products. You see, the thing about when we're talking about blood transfusion, we're talking about the volume and the cellular component. There are two things there. The volumes, if there's massive volume loss, it's detrimental to the health and life of a patient. And if there's cellular loss, especially the PCV, it's also detrimental to the health and the life of a patient. So along that line, we find that there are some products that actually can, in the interim, while the body is trying to regenerate, replace the volume of the blood, because there's a minimum amount of blood, volume that should be inside our vessels for our heart to function very well, to be able to carry oxygen very well. So that amount should be maintained. Where we have a massive loss and there's a reduction in blood volume, we use plasma expander. We call this blood expander. What's generally they call blood expander, but we call it plasma expander. The Hemacet and the others. In case of emergency, when Hemacet is not readily available, our normal saline, the one that we usually use, come in play. We can use it just to maintain the volume. And as for the cell, we know that that one takes a while before it builds up. So we look into the process of how the cell is produced in the body. And we find a pathway. One of the products of the pathway is one that can be synthetically produced. They can produce it in the laboratory in form of an injection. So erythropoietin. I'm sure when I say this, whichever witness know about it. EPO, erythropoietin, it's a natural component of the body. A very it's like a precursor when the body is regenerating blood cells. So it comes in play. So when we administer it, it kind of flog, so to speak, flog a horse so that it walks faster. So it's nothing but we're trying to help, as it were, nature to do what it's supposed to do. Yeah.
Now, doctor, let me ask you this very germane question. Are blood transfusion compulsory during some health issues, such as jaundice, for example?
Yeah, sometimes it gets to a point when there's jaundice in children, we don't have an option than to transfuse. Yes, we call it exchange blood transfusion. Because if you don't do that, that jaundice can result to permanent damage for the baby. We call it kernicterus. When the baby has kernicterus, he has some some motor function deficiency, even cerebral nutrition deficiency. The child, to put it in layman time, become kind of a problem child, So when we have that situation in our hand, a baby with rising jaundice, a jaundice that is keep increasing, there's a level that when it gets to that, we know the brain is affected. So our practice, the way we are taught and the way we know from now to now is that when that happens, what we can do is to exchange that blood. We'll bring out the blood of the baby, then infuse with a fresh blood. So that's it. It's a basic and standard thing.
But wouldn't there be complications when that happens?
Well, with any treatment, there's complication. With any treatment, there's even with administration of vitamin C. As common as vitamin C is, I've seen people reacting to vitamin C. I've seen people coming, with problem, complain, and we could trace it to their intake of vitamin C in excessive dose. So any administration, any treatment has its own inherent complication in it. A medical doctor, a medical personnel is faced with that, having to balance the risk and benefit of a particular.
Now, let me ask you this also, because you've actually pointed it out during this course of this interview, and medical doctors have talked about seeing their patients as early as possible, kind of figuring out what they will, what they won't accept, and when you get time to walk through that. We're not talking about treating patients with preopnia or anemia, for example, like you said, with erythropoietin, EPO, and iron. Is there anything else that we will need to think about in these routine patients, for example? And are there medications they might be or they should be on?
Well, it's not all about medication. Now, I said the general principle is it's like a wait and see game. Though there's a little push because of what we are administering to the patient. Wait and see in the sense that we know the body will regenerate over time. So it's not about administration of drugs or medicine. Though it has its place, a huge place, which we cannot contend with. But other things we could do, in fact, the overall management of that patient, or a patient with a low PCV, you don't want her to engage in some activities that can tip her into crisis. You manage comorbid states. Comorbid states means if she has a low PCV, it's not the only problem. Something must have been responsible for that low PCV. You manage that. You manage it effectively. You understand? So that's one thing. Because if you don't do that and you just concentrate on let's build well, it's like pouring water in a basket, so to speak. So you manage the comorbid stage. You kind of restrict the physical movement, because if they move and they are active, it challenges the heart. The heart wants to beat faster, and it's beating faster and just pumping blood that has low oxygen capacity. You can tip them into crisis. So it's not about like I said, management of comorbid states, the physical, attending to the physical needs of the patient so that it doesn't engage in activity that can cause tip him or her into crisis. Then the administration of not only EPO and iron. We still have, I have kind of become, how do I put it now, a student of Jehovah's Witness. Okay, they come up with a lot of this natural thing, that they use, and though I don't have an empirical evidence, I can't say, but from my experience over time, we know it works. But I wish there could be a study, or maybe they can raise body of scientists, to study each of these solutions they used to prescribe. Ugu solution, for example, Porokoro Baba, for example. Now recently they are using tomato, and so many things. And sometimes in isolation, even without administering erythropoietin, I see that. To my consternation, sometimes I feel the improvement is massive, and I was like, what did you use this? They just use this and that. Well, as a scientist, I'm not leaning too heavily on that, but at least I'm inclined to say that these things are working if there are no side effects.
Finally, doctor, because we want to make this as practical as possible for our viewers who are watching. I would like to take you through a scenario, and I want to see how you take us through how you handle that kind of a thing. For example, a woman who has come in, who has had maybe multiple C-sections, for example, before, and is about to deliver, and the nurse or midwife realized that she is a Jehovah's Witness, and she's not, accepting blood, and perhaps this was not communicated beforehand. And when she also came in, with a hemoglobin that is approaching maybe 10 GDL, so to say, very low PCV, so to say. How do you deal with situations like this, sir? Okay,
well, you said CS, but I would want to say the ones that are more dramatic are the one that presents with fibroid. Multiple fibroid, they've lost blood over time. Yeah. And they are already, operating on low level PCV, and suddenly they have a crisis. The crisis is massive blood loss without. So, I want to, if you don't mind, just relate one experience, the case of Jehovah's experience that really emboldened me, encouraged me along this line of managing Jehovah's Witness. We had sometimes in 2010, I have the record, but I'm not too sure. But so this Mrs. ABC came from another hospital. No, in fact, from a general hospital. It was at a point, to summarize it, she had multiple fibroids, and I don't know. But it's an experience worth sharing, So she came in brief, she came in with PCV of 19%, and she was still bleeding. If measures from one private hospital, before they went to general hospital, from general hospital to another private hospital, before they now came over to my place. So 19%. So we had it was a very difficult options we have. Either we stay idle, because after asking her what have they used, there was practically nothing for me to do again to stop this bleeding, because they have used everything there is in theory. So it's either we just wait and let her bleed to death, or take her to theater and then do something, and just so the whole, in fact, almost the whole congregation, our whole congregation everybody was there, the mother, the husband, everybody. So they opted for the surgery. It was a challenging moment, I would say. So going in with 19%, and so I wouldn't say it's an heroic adventure. This is we are faced with a case of two evils, as they say. So we chose to go the way of the lesser evil. And waiting, we had to do all the intraoperative measures, maneuver, so as to reduce blood loss. But in cases like that, it's inevitable. They will bleed. Eventually, we finished it, and the PCV dropped to 9%. 9%. So we had to now institute the non-blood transfusion management, all that I've highlighted earlier before. And she survived it. She made it. And the interesting thing about it is, without gainsaying, is that she left the hospital on the 7th day. And it was she left when the PCV rose to 23%. So this is an emergency. But if I have a case like that, you paint a scenario of an emergency. And I've earlier mentioned that I would love that people with such present early, because we manage the situation before the surgery, we manage the situation during the surgery, and we manage the situation after the surgery. So there's pre-op, intra-op, and post-op management. It's all about, having, since we have that in mind, we want to, as much as possible, avoid blood transfusion. So we take measures before the surgery. And in doing that, if it's something that can be, we have two kinds of surgery, emergency and elective. I've just talked about the emergency. The elective one, we this surgery can go on in 2-3 weeks time. Okay, in that case, let's start the process of building up blood. Let's start the process of losing blood. Do you understand? So that's what we can do before surgery. During surgery, in fact, there are so many things now that has been discovered that we can do. We can have the diatemic coagulative electrocoagulatory surgery, where there's minimal blood loss. Once you are cutting, you are clipping off even the scalpel is there now. Once you make an incision, it's there to coagulate the blood, it doesn't flow again. So those are things that non-blood transfusion has challenged us, and even the engineering department, to come up with. Okay, these people say they are not taking blood, well, how can we help them? So these are things that can be put in place. And after that, then comes the post-op, what I have highlighted earlier before. So.
Thank you very much, Dr. Wakaya. Well, I'd love to take you more questions on it, but we need to time for that. But we'll hope that other time we'll have this opportunity to meet you. Thank you so much for this insightful analysis.
My pleasure. Thank you.